good day, good morning, good afternoon, good day wherever you are in the world. And I'm excited to welcome you here to this Research Insights webinar today. My name is Jane Miles, and I serve on the board of TMA as somebody living with dermatomyositis and somebody who works in clinical research and development in my professional life. So today, I'm really excited to host this with you, and I'll be learning right alongside with you. Just before we begin, please note that we're recording this. It will be made available on the TMA YouTube channel next month. And you can please drop your location with your country or your state into the chat so we know where you're coming from today. Also, use that chat, the Q&A feature at the bottom of your screen. You can see it. There's a little box with a question mark in it if you have questions that you want us to try to answer during the course of the session today. So today, we're very delighted to host Dr. Julio Huapaya. And the topic is finding better tools to track and treat lung disease in myositis. Now that's a really big problem, and we need lots of better measures to track lung disease. So this is perfect timing, and I'm thrilled you're here with us. Lung involvement, especially the interstitial lung disease or ILD, is one of the most serious complications associated with myositis. I remember doing my pulmonary function tests when I was newly diagnosed. Fortunately, it was okay. But that early detection, regular monitoring, and tailored treatment makes such a huge difference in the outcomes and in our quality of life as patients. So that's where tracking tools like high-resolution CT scans, pulmonary function tests, patient-driven symptom logging all come in. But Dr. Huapaya has some new things that I think are kind of even more exciting. So we're very privileged to be joined by Dr. Huapaya today from Johns Hopkins. He works at Hopkins and at the NIH Clinical Center, and he received some funding from TMA to do a pilot study that explored combining clinical data, imaging metrics, and patient-reported tracking to try to better detect and maybe even predict lung function and how things are going. I'll just tell you a little bit about Dr. Huapaya before we get going. He has lots of data to share. So he's an assistant professor in pulmonary and critical care medicine at Johns Hopkins and a recent critical care fellow at NIH Clinical Center. I think you completed your fellowship training in pulmonary and critical care at University of Maryland, so kind of close to Johns Hopkins, and then did a critical care medicine fellowship through NIH in 2023. But you were board certified in multiple disciplines, which makes you a very special person working on behalf of myositis patients. It looks like your interest is focused on myositis-associated interstitial lung disease, and especially in antisynthetase syndrome and anti-MDA5 antibody-related lung involvement. So I'm really excited to hear directly from you what you've been doing, how that funding from TMA helped you, and where you think we're going with respect to better understanding when lung disease is starting, maybe how to intervene better, and then how to predict how that tracks with disease progression. So Dr. Huapaya, over to you.
Good afternoon, everyone, or good morning to others. Jane, thank you very much for the very kind introduction, and thank you to the Myositis Association for inviting me to be here today. And I love seeing patients and talking to patients, so I'm very excited. And the research we're doing, and as you said, we're very fortunate that we received some funding from the Myositis Association, and the findings that I'll share with you today get me very excited, and I think the results we are getting more and more are very promising to really make changes in the life of our patients, which is what we aim for. And with that, let me share my screen. Okay. And I'll just ask Jane for confirmation that you can see my slides adequately.
Yep, they're perfect.
Perfect. Okay. So to start today, I'll just highlight why do we care? Why is interstitial lung disease, or in simple terms, lung scarring, so important in patients with myositis? We know that it's associated with lots of issues and high mortality, even in some patients, and the course can be unpredictable. Despite the fact that we do see that patients improve with treatment, we know that up to 50% of the patients may get worse after treatment. And this is because, unfortunately, while we do have PFTs or lung function testing and CAT scans, those tools are not great at early identifying what's happening in our bodies, and there is a really important need to identify biomarkers that can help us to predict changes earlier. And here, just for some of you who may not have looked at a CAT scan or a picture of your lungs, I wanted to briefly show you the image on the bottom left. It's a person laying down on the back in the CAT scanner, and the circle in the middle is like the heart and the vessels around the heart, and the two black areas filled with some lines. That's what we would expect for normal lungs. And air in the CAT scan looks black, so that's two lungs filled with air. That's normal. In the middle image, we have what we would call inflamed lungs. And some of you might have heard pulmonologists say, oh, you have this ground glass or just shadows, which translates to inflammation. But then this can progress to what we call fibrotic or scarred lungs. And this is where we start to see these black holes that are replacing some of the normal lung tissue. And this is what, in ideal world, we would try to avoid by identifying tools that allowed us to treat the patients better and avoid getting to that point. Briefly, in terms of diagnosis and classification, I like highlighting the classification that was published back in the 70s by Dr. Bohan and Dr. Peter, where they were able to come up with this criteria to identify patients with myositis. And the two terms that some of you might have heard or used is dermatomyositis or polymyositis. And this is based on having weakness. Sometimes we get the muscle biopsy, we get some muscle enzymes and a rash. But in the past, I would say 5 or 10 years, we're learning more and more about how myositis is really just a big term that actually has different subset of patients that have very different behaviors. And right now, antibodies are very important for the diagnosis. And I'm very excited to share that the group at NIH, led by Dr. Andrew Mamen and Dr. Pinel Fernandez, they're doing fascinating work showing that these autoantibodies may actually be causing disease. So rather than just being markers for diagnosis, they can actually have a more important role in causing the disease. Now, to put this in perspective, we have certain antibodies such as TF1 or SEA that usually give you a more skin predominant disease. We have other antibodies such as SRP or HMGCR, and you don't have to remember these antibodies, but this is to highlight that these antibodies give you a more muscle predominant disease. We have some others such as MI2 and NXP2 which give you both skin and muscle involvement. And then we have a panel of antibodies, which is the panel that I usually see which is composed of patients with these anti-synthetase antibodies, and these just are antibodies against a specific protein inside your cell, and also MDA5, which some of you may know it's associated with rapidly progressive pulmonary fibrosis, and that's why there has been a lot of interest in that particular group. Now, years ago, with the Hopkins group, with Dr. Danov and Dr. Pinal Fernandez, we published some of the differences across different antibodies. And here, what I'm showing you is how the lung function was different for three different groups of patients with myositis with different antibodies. We have anti-Jo1 in blue, anti-PL12 in orange, and anti-PL7 in green. And again, you don't have to remember the types. But the bottom line is that we saw that patients with certain antibodies had more severe pulmonary fibrosis over time. We also collaborated with Dr. Andrew Mamet and Dr. Pinel Fernandez, and also look at specifically patients with MI2 antibodies and compare them to other types of myositis. And clinically, we observed that these patients were significantly weaker. Their enzymes of muscle damage were worse compared to other patients with myositis. Now, I'll spend a minute talking about the test because this is what we do in routine practice. And what you usually hear from your doctors is, well, your panel was positive for antibody X, Y, or Z, or we didn't find an antibody. And here I'm showing you a picture of what we consider is the gold standard. And the gold standard for testing in medicine mean what do we think it's the best test? And in this case, it's immunoprecipitation. And you can see in this red square that there is a line. So if you have this antibody, you have a positive line and it's reported as positive or negative. Now, briefly, for some of you, what is an autoantibody? And the way I like explain it, this you can imagine these are like body's custom-made Velcro hooks that stick to anything that shouldn't be there. So usually our body develops antibodies against viruses or infections, but it can develop autoantibodies to anything. So if you get a cold, your body will produce antibodies to get rid of the cold. But unfortunately, due to multiple factors, sometimes we're seeing these autoantibodies against a specific targets in our own immune system. So these are autoantibodies that we're seeing in myositis. Now, as I mentioned earlier, in practice, we mostly just get yes or no. So we don't really quantify them. And the reason for that is because until recently, we just thought that there were markers of disease, but we didn't know how important they may be. And just to give you an idea, if you think in terms of amounts, if you only have a little bit of antibodies, like a teaspoon, if you have a tablespoon with a lot more, or a cup or a pint, you can imagine that the more antibodies you have, the more immune response you may have, and maybe this could correlate with markers of disease activity or treatment response. But the biggest limitation has been testing. How do we accurately quantify this? And this is where our team, in collaboration with multiple institutes at the NIH and with Johns Hopkins, and then by receiving funds from the Myositis Association, we were able to look at a specific assay that I'll discuss, which was developed by Dr. Peter Borbello at NIH, that it's highly quantitative. In addition to that, our lab at the NIH, led by Dr. Anthony Suffredini in the proteomic world, we have developed techniques to better identify a lot more biomarkers, and I'll talk about it in my next slides. Ultimately, what we want to achieve is to really have better tools, biomarkers to measure disease activity even before you are symptomatic. to also look at treatment response early on before the inflammation and the damage is done, and also to better understand the biology of the disease, what is causing this, what's the role of these antibodies. Ultimately, what we would like to achieve is precision medicine and get specific panel of markers that can help us differentiate different types of patients and their progression. So the big question we had at the beginning was, are there any new methods that can better measure autoantibodies? And the answer is yes and no, because we don't have a new method, but we do have a method. And this is the luciferase immunoprecipitation system. And in simple terms, you can imagine what we do is we attach the antibody target to a light emitting tag. And the brighter the light gets, the more antibody you have. There's a linear correlation. And this test, even though it's not available routinely, it's more for research purposes. It's not very expensive. It's highly reproducible and has been used in other diseases. And here I have a list of high impact factor journals where Dr. Peter Burbello has published how he has used this assay in multiple diseases with really great results. And when I met with Peter Burbello back 2, 3 years ago, we decided to start looking into this, and he is able to construct the tools that are necessary to identify each antibody. So we started very small, and with Dr. Lisa Ryder, who some of you may know of, with the group, we started to look at, can we quantify anti-Jo1 levels? Let's start small, and we were able to successfully do this. We identified 5 patients in a cohort of 30 patients with myositis. And here what I'm showing you is the autoantibody levels on the y-axis. And this is measured in light units because we're looking at light as a correlate of the amount of antibody. And on the x-axis, we have healthy controls who shouldn't have antibodies. We have patients with Sjogren's disease, which is another autoimmune condition. And we have patients with myositis. And the dotted line represents normal versus abnormal. And what you can see here is that these 5 patients who had antibody levels had high levels. And of note, this is a logarithmic scale, so you don't see a huge difference, but the median value was around 1 million. And this was 1,000 times fold higher than in the seronegative patients. And we were able to identify 5 other autoantibodies in myositis. Although the sample size was small, this was very promising, and this was what we used to present data to the Myositis Association and get funding. In this small study, we also look at a few subjects who had longitudinal assessment of their autoantibodies over 1 year. And to highlight, you see the top left shows the antibody levels, again measured in light units. And you see how most of them are declining after getting rituximab. On the right panel, you see the lung function, which is measured by the forced vital capacity, and you see how the trend is that it's going up. On the lower left, we have CK, which is one of the enzymes of muscle damage. And you see that it's also trending down. And finally, a global assessment scale that it's also trending down. So you can see how these levels of autoantibodies parallel the clinical improvement and improvement in the muscles and the lung function, which made us think, can we really use antibodies as markers of disease activity and treatment response? And again, a huge shout out to the Myositis Association. By now, we have measured autoantibodies in more than 250 patients, from patients who were seen at the NIH in different institutes, and also from Johns Hopkins or the Myositis Center. And here, and again, showing you the antibody levels measured in light units with LIPS with this luminescent profiling method. And on the x-axis, I have different antibodies. So we have measured close to 200 patients with anti-Jo1 levels, MDA5, PL7, PL12, EJ. And again, you don't need to remember the types, but we are able to quantify these levels. And we recently compared in 131 patients with these antibodies who also had immunoprecipitation. And you remember immunoprecipitation, it's what we consider the gold standard. And while it's the gold standard, unfortunately, it's very expensive and it takes a long time. It takes like 3 months sometimes. And you can see that LIPS adequately identified 129, so 98, 99% of these patients. Data that I'm not showing you today, but we also compare LIPS with the traditional line blood, which usually takes less, like 2 to 4 weeks to come, and LIPS was significantly better. This is also new data that we just developed recently. We obtained samples from the Johns Hopkins Myositis Center, and here I'm showing you the antibody levels on the left side, on lung function on the right, and on the x-axis, I'm showing time. And as you see, we're talking about samples who were followed or who were obtained for more than 15 because with our assay, we were able to detect Jo1 levels early on, and these levels became negative over time. And on the right side, what you see is that the lung function over time became normal and stable. This is in contrast to the patient in purple who the first time the patient came to the hospital, the levels were relatively moderately to high and they were persistently high despite therapies. And you can see that the lung function was also slowly declining and did not recover. And we're planning to do a lot more testing looking at longitudinal samples, but this was really, really impressive in terms of the potential power of using antibodies as biomarkers. Now, switching gears slightly, what about other protein biomarkers? Can we use them to improve how we monitor treatments? And also, can we use proteomics to discover new molecules, new pathways that can help us to understand the biology of the disease? And to easily explain what is proteomics, I think most of you may be familiar with the CK. So the CK, it's a muscle enzyme that gives us information on muscle destruction. Some of you might have heard when you were diagnosed, your CK is high. Once you get treatment, it goes down, and over time, it normalizes. But this is just one single enzyme. What if we look at hundreds and thousands of proteins and we start to see patterns at baseline and over time? And this is where proteomics can help us significantly because with a single test, we can take a look at hundreds to thousands of proteins to better understand patterns of inflammation, tissue injury, or healing and repair activity. And I'm not going to talk specifically about the proteins and the pathways, but I just want to give you a sense of the work that we're actively doing. We started with a small study. We look at 40 subjects and we look at an assay that interrogated 3,000 proteins using a single blood sample. We included 15 patients with Jo1, which is again an antibody associated with pulmonary fibrosis. We included 15 patients with what I call pure myositis because they don't traditionally get interstitial lung disease, such as NXP2 and MI2s. And the figure I'm showing you, it's a heat map. This heat map has the healthy controls on the left, the patients with myositis and a Joan antibody on the right. And each column represents a patient. Each row represents one protein. And what you see is that on the lower right, there's a lot of red. So these are proteins that are upregulated in Joan patients compared to controls. And we identified that out of the 3,000 proteins, there were 250 that were very different between Joan and controls. And when we look at these proteins, several of them were involved in muscle and tissue inflammation, immune system. Some of them had lung-specific roles, which was fascinating because we're seeing these in the blood, and also some other proteins involved in a stress response. Recently, we completed a larger study on more than 200 patients with multiple antibodies that you can see the breakdown there. However, this was a targeted proteomic study. So we only look at 184 proteins. And I say only because you'll see my next slide. But this was very targeted, and we're still seeing differences. Roughly 30 to 50% of the proteins, depending on the subgroup, were different compared to controls, and we're actively analyzing this data. And this is the slide that gets me extremely excited because with a lot of support from the Myositis Association, from the NIH, from Hopkins, and again, multiple institutes within the NIH, we just received our data on looking at more than 240 patients, and we interrogated close to 11,000 proteins using a single blood sample. And you see, we included lots of patients with JAW1, MDA5, and different antibodies. And for this study, we also included a group with IPF, which this is just a non-autoimmune form of pulmonary fibrosis. And we're currently analyzing the data, but I wanted to give you um, some information today. So on the right side, we have the volcano plot that compares myositis ILD versus controls. The red dots are proteins that are different from a statistical perspective compared to controls, and these are up. And you see there are like 1,000 proteins that are upregulated in myositis ILD versus controls, and a little bit more than 200 that are going in the other direction. So this is fascinating data that we hope can help us not only to better understand the biology of the disease, but also try to look at potential biomarkers and targets. And this is where my next slide comes. This is so you can imagine, well, doctor, how do you analyze thousands of proteins? That's going to take you a long time. And that is true. One of the methods when you look at high density data where you have thousands of proteins is you do something called pathway analysis. And the way to do this is you can imagine there is the inflammatory pathway or the fibrotic pathway that involves 200 proteins. So you see how many of those proteins you have in your data. And to make the story more concise, you can see what pathways are important in your data. And again, this is just to give you a brief example using the targeted data from our 184 proteins. We were able to see that the IL-6 signaling pathway was enriched in our data. And again, this will help us, especially when we look at the 11,000 proteins, to potentially look at other pathways that could become targets for new medication. And then we move to the third part of my talk, which also gets me extremely excited because up to this point, everything I've shown you, it's based on using what we call retrospective data or biobank data. And this is because of all of you, because all of you help us to get a little bit of blood to better understand and get answers for research purposes. So everything I've shown you, it's what we're doing. But also, when we look at that, there's a lot of things that we cannot control, right? Multiple patients are multiple therapies. So, what we know we have to do, and we're working on that actively and hope to get this started in the next 6 months to a year, is to do a study and look at this prospectively. Now, before I go into the specifics, I just wanted to show a couple of slides. With Dr. Danov and the Hopkins group, we published this paper in 2019 where we look at the effects of two medications, azathioprine or Imuran, that some of you may be more familiar with, or mycophenolate, which both are used to treating myositis. And what we saw is that both drugs were comparable in terms of improving the lung function and help us to reduce the steroid dose, which we all know how bad steroids are in terms of side effects. And even though they're amazing at helping to reduce inflammation, we try to reduce the dose as much as possible as we can. We also published a second study looking at the role of immunoglobulins for specifically for patients with antisynthetase syndrome associated ILD. And we also saw that the lung function improved on these patients. Now, most of these patients had already failed 3 or 4 agents, but we still were able to see an improvement in their lung function and a decline in the steroid dose use. But when we work on these papers, Dr. Danov and I always talk, wouldn't it be super incredible to have something early on that tells you you may respond to this therapy better to this one, or early on we need to change or make changes in terms of a second agent or higher dose, and that's what we're lacking right now. And this is why we're very excited that now that we have a lot more data to support our hypothesis, we're going to be looking at 60 patients with myositis, ILD, prior to starting a new therapy. And this will be open, so patients could be started on a T cell. T cell is one of the soldiers that helps your body, or anti-B cells. And so we're going to look at all these patients with the goal of identifying key trends in autoantibody levels in response to therapy. What we think is going to happen is that measuring your autoantibody level at baseline, like the purple patient I show you, if you have super high levels of autoantibodies, that might tell us something. And also the change, if we see that the antibody levels go down, that may help us to predict treatment response. We will also do the same with proteomic analysis, looking again at response to therapy. And our hypothesis is that both at baseline and the follow-up will help us in terms of predicting who may respond or who may develop a flare. Now, this is the second part of the study, which we're also very excited because there is another technology that it's based on microsampling kits. So you can just get from your finger stick up to 100 to 120 microliters. And you can imagine what we would like to do, and it's our dream. Can we tell patients, get this kit to your house, record your symptoms, and then we will then measure antibody levels and targeted proteomics, and we'll have a more close monitoring system. What we hypothesize is that probably we'll see changes in either antibodies or proteins before patients develop symptoms. And that would be a huge thing to have for this reason. And I'll put this in a clinical perspective. So if we get a patient who has very high levels of antibodies, like the PINT example, these patients probably are a high risk for disease progression or treatment failure. So they need closer monitoring, maybe need increased immunosuppression. In contrast, if I have another patient who maybe doesn't really have as many antibodies, maybe he or she just have a teaspoon of antibodies, well, this is a very different patient that may not require the same treatment as the first one. You may be a low risk and you may need less frequent monitoring. But then at baseline, as I keep monitoring you, either in clinic or with the microsampling kit, then I see that this patient who had a pint of antibodies now has a teaspoon of antibodies. Well, that can help us to lower immunosuppression or the treatment because we all know that the immunosuppressant agents also have side effects. So we can try to lower that with a better tool that would be very beneficial. Similarly, if you came the first time and only had a teaspoon of antibodies, but now you have a pint of antibodies, even before you are symptomatic, maybe there is a role to give you more immunosuppression and then avoid you developing symptoms. And so in conclusion today, I think, or I hope to have shown you that measuring autoantibodies with these advanced tools such as LIPS that we have at NIH, we strongly think that they will help us to better understand the patient's risk, hopefully track disease activity, and see how well treatments are working. We really think that autoantibody levels may actually reflect real-time immune system changes. And this is why we think that these devices, such as the microsampling kit, where you don't have to come to clinic, you just mail us and then we run the antibody testing, might help us to have better insight into the clinical activity of the disease. And lastly, we think that with proteomics, we can find new proteins and new pathways to help us understand the disease better and ultimately develop more targeted and effective treatments. And I will finish giving a huge shout out to Dr. Anthony Sufridini, who is my mentor at the NIH, Dr. Sunny Danov, my mentor at Johns Hopkins, and Peter Burbello, who I have to say, Peter is the one who created LIPS, and he did a lot of testing for us, even when we had no money, but just because he believed in the science. And lots of people that you may recognize, such as Dr. Mamet, Dr. Ryder, Schiffenbauer, Dr. Punal Fernandez. But in reality, every person here has done a huge amount of work from data gathering, analysis, and a lot of help. The Myositis Association for believing in us early on, the NIH folks who also help us, and lots of patients from the Johns Hopkins Myositis Center who contributed to make this happen. And with that, I'll take questions.
Let's see. That was awesome. Thank you so very much for that amazing discussion. And you know what? I really love all your slides, but the last one really got my heart because it takes a community for research to make progress. And you've really illustrated that beautifully here. So thank you for everything you're doing and for working so hard with all these other great leaders in the field. I appreciate that a lot.
Thank you. Thank you.
All right, it is question time. I'm going to start with one that might be simplistic. I wouldn't know how to answer though. And the question is, which antibody is the most common for antisynthetase?
That's a great question. So Jo1 is the one that we most commonly see. And if you remember one of the graphics I show you, that's where we have done testing on probably 200 patients by now. And even though, in the community, people may say it's rare, we do see it very frequently. And that's the most common antibody in the antisynthetase family. That's a great question.
I'm still waiting for my autoantibody results. So
keep me posted.
we'll see if there are any. So let's go back to LIPS. I love that assay, by the way. Having
Yes.
done the immunoprecipitation in the lab like centuries ago in terms of science, how do you think that this might apply for other myositis subtypes or even other autoimmune diseases? And what if they're not linked to lung? What if it's linked to some other symptomology?
Absolutely. That's a wonderful question. And that's something that we are currently expanding because the beauty of lips, and again, this is all because Dr. Peter Burbello developed this years ago, you can virtually build what you need to detect any antibody. He just has to build it. And so recently, we also worked with the Scleroderma Foundation, and we were able to look at SCL70 antibodies, which is our antibody specific for scleroderma. And even in the myositis patients without lung disease, such as MI2s or NXP2s, Peter recently developed the construct to be able to measure MI2 antibodies, and that's a work that he's also doing with Dr. Mamin and Dr. Pinal. And last 2 weeks ago, before he went on vacation, he said that he got the construct to build the NXP2. So it just takes time to build the construct, but we can virtually again build any one we have for any autoimmune disease. We just need Peter's expertise to build it in the right way and then do the testing to be able to confirm that it helps. But I'm also extremely impressed by, and I think I shared this with Linda when we talked last year. To me, it's incredible that we haven't taken advantages of this unique assay to better help our patients. But now we're doing it. So
Adoption is different than progress.
yes, yes, you're absolutely
I
right.
work a lot on the adoptions. And when you say build a construct, I'm trying to imagine that in my mind. Is this like a Lego kit where you just have parts on a shelf and you put them together, or what does that mean?
Yeah, yeah. So to to make it in simple terms, you can think it's like a Lego place. And in fact, I was debating sharing this or not today, but you got me very excited, so I will. Um, Peter is also working, and we are working, all together to have another test that is similar to lips, very similar. It's like a similar concept because you have this luminescent based assay that looks at light, but this one in particularly, you can think of it as a Lego device. So he has to get two pieces, put two other pieces. So if you have the antibody, then they will grab the antibody, and then you'll have the light. And we're incredibly excited. Again, if lips was or is amazing, this other assay has a lot of potential, and that's where we're currently working on. But even with lips, again, the range of quantification, because it's so specific, it's is very, very a huge unique advantage.
Oh, I can't wait to talk to you privately more about this. But we have another really good question in here, and um, there's a couple. I'm going to start with this one because you did touch on this, but let's go back to it.
Yes.
So the question is worded this way. Sorry if you mentioned this, but are the antibodies the problem, or are the antibodies to an abnormal protein the problem? Or do we know?
Great question. Great question. So until recently, we just use antibodies as a diagnosis. So if you had a Joe one, well, you very likely have this myositis disease associated with this Joe one antibody. We thought it was just a marker, but in really fascinating research from Dr. Mamin and Dr. Pinal Fernandez, they recently, specifically in patients with MI2, they were able to put the antibody into a muscle cell and see what does the antibody do. And what they saw was similar to what we see in a patient with MI2. So their data highly suggests that these autoantibodies are actually causing disease because they're causing a dysfunction in the protein. So you have a normal protein that has work to do in your body, but then you have this antibody, and for some reason it's blocking that protein to just do normal work. So you start to develop problems. And this is why some patients may be on, rituximab. Rituximab helps to lower antibodies, as you also saw some of the patient data we showed. But there's more than that. So there are more than just looking at antibodies, but this is the first step. I think to me, the role of autoantibodies is growing, and it actually makes sense because, if you think about it, 20 years ago, if you had a Joan patient with bad lung disease and you had a patient with MI2 who never develops lung disease, you would call both myositis. But in reality, they are like very different. And we know that. So even though, again, this myositis is a huge umbrella term, with the recognition of antibodies, we are better, more precisely getting subgroups. And what I envision is, okay, but even within the Joan patients, we have Joan patients with really bad ILD. We have some Joan patients with mild ILD. What if the antibody levels is can help us to cluster patients and then help us to have a different treatment and just not treat everybody with the same regimen, if that makes sense.
That gets me excited, but that's because of my old oncology work. Um, so here's a great question. It's more of a clinical question than a research question, but you'll be able to answer this. 2 years ago, I was told I didn't have antibodies visible when tested.
Mhm.
Do I need to be retested or should I recheck? And what do you think?
That's a yeah, no, that's a great question. And that's something that, so my first thought is it highly depends on what testing was done. If the testing was what we consider the gold standard, which is immunoprecipitation, I would believe that result up to some extent. If the testing was another testing that it's more commonly available, like a line blood or an ELISA, I would be a little bit more hesitant to fully believe that result. And I think that on some patients, depending on, case by case, we do retest and look for antibodies again. And the last part that I'll mention is, and this is something I learned from Dr. Danov, sometimes we have patients who clinically have interstitial lung disease or pulmonary fibrosis, and they look like myositis patients, and they don't have an antibody even by immunoprecipitation. And this is beyond this talk, but you also have to remember that we only we can only find what we know we're testing for. And to give you a concrete example, out of this family of synthetases proteins, we only test for 8. There are 12 others that we don't routinely test. And Peter is working on being able to test those. But you can imagine that if the current testing we have for clinical purposes only includes 12, you may be negative for those 12, but you could have some of the others that we're not right now testing. Now, our goal would be to test all of them in an efficient way, but that's what we're going to be working on with Peter over the near future. Be able to do a lot more testing, even on those rare potential antibodies.
Headed more towards that proteomics approach to
Ye-
testing, right?
Yes,
Yeah,
yes. You're up.
that's really
See,
cool.
Yeah, you're becoming an expert on this too.
I worked at a place that had a lot of expertise.
Amazing.
So let's go big picture again. Why
Mhm.
did you get interested in ILD?
Oof, that's a loaded question. So, to make the story short, my father, it's a pulmonologist, and I still remember as a kid, I was naive in a way, and he would tell me that he had a lot of challenges with patients with pulmonary fibrosis, especially the idiopathic, which stands we don't know what's causing it. And still remember again me being very naive. I told him that, but this is 2020 2020, 2012. Hey, there gotta be treatment. Like medicine has advanced so much. And when I look at, in the literature, there wasn't. And there was nothing we could do for these patients who are struggling to breathe. And I still remember how he mentioned, son, some patients do improve on the treatment, some don't. And I'm from Peru, I was born there. What I know now from a lot of learning from Dr. Danov is that um, probably, some of the patients my father saw who did improve with treatment, probably they were myositis patients. They were just never diagnosed because we didn't have this testing in Peru. And even right now in the US, we do see patients who are referred to our clinics with the label of IPF, which is we don't have good treatments for that. But when we do the testing, oh, actually, you do have an antibody. And so I was very, very fortunate that I met Dr. Dano when I was a med student rotating at Hopkins. And when I saw those patients improve with fibrosis, I was like, wow, we can do this. Of course, then I learned that there's so much need. And I was also very fortunate that Dr. Anthony Sufridini has been extremely supportive at NIH. And with these great collaborations, it's like there is a huge need. We can cover this, not with one person, but with thousands of people to make this happen.
I love the relationship between your father's work and how that's influenced your work. He must be so proud.
Oh, thank you. Thank you.
Let's see. Okay, so looking forward, where do you think things are going to go? And what therapies or technologies are you exploring? And I've got a sub question there. Like, how does that data change, those markers change in our patients if they've been through CAR T therapy?
Hmm. Wow, that's a very advanced question. So, in terms of what is next, as I briefly showed today, we already have three studies on three different proteomic platforms, and we do think that they are complementary. So right now, sitting in my desk, there is a lot of data that we're processing, and we have very advanced statisticians and bioinformaticists who are being extremely, extremely helpful in terms of better understanding what does this protein profile mean in terms of having these hundreds to thousands of proteins. So we hope that in the next, I'm very ambitious, but I hope that in the next 3 months we'll have at least a couple of those studies ready,
Wow.
and maybe the biggest one where we measured close to 11,000. I hope to have that in the next 6 months. So I hope that the proteomic data that we are developing should be available um, for for the literature to have in the next 6 to 12 months. But at the same time, again, lots of support from Dr. Sufridini and Dr. Danov. We want to start getting the prospective study going, because the big limitation of all this retrospective data is that there's nothing I can control great on treatment, even though we're trying. But if we do the prospective study, and especially the microsampling kit, I didn't mention this, but Peter confirmed that he's able to quantify antibodies from the microsampling kit. So we are very excited, and we at least want to explore, because if that holds up and we can identify changes, that's just the beginning, right? Like we can do that for all the antibodies, we can do closer monitoring and talk to other partners in the area. We have really good relationship with Maryland, with Hospital Center, Fairfax. So we can just expand this at a higher pace. And about the CAR T, that's a great question. And I think, I sometimes I'm thinking to reach out to more and more people to get more samples and do more antibody testing, because if you don't look, you're not gonna find anything. So you have to at least look for it. And I think at some point, if there is opportunity to look at these patients or get samples, get collaborations, we can start looking at, well, what's happening with your antibodies. Recently I work with Dr. Sean Agbor from NIH, and he has some patients with pulmonary fibrosis pre and post transplant. I know it's a big question that we don't know the answer for. What happens with patients' antibodies after transplant? And
Right.
that's also something we're going to start looking at. So there's a lot of things that Peter Burbello jokes. I wish there are two or three of each of us so we can do more work.
Well, we'll just make an AI clone of you. And um, actually, that point that you just made relates to a question that came up a couple of times in the chat, and people want to know how could they help your research? So, is there a place where they could donate their samples, for example?
That's that's a great question, and you know, we've been meaning to talk to the Myositis Association and to patients and see if there is a way to get data directly to the NIH or through Hopkins. Um, we have some funds. We recently actually bought the micro sampling kits. So it's more of the setup that we're working on over the next 3 months to get the protocols, the research protocols approved. And we would love to find a way to collaborate with, again, the more, the better. So there are easy ways to just be in touch with your main doctor at another state or another hospital, and with your approval and your permission, we can just get your blood or your samples mailed. So that's my ideal would be to really do that. We'll launch the study, 6 months from now, and get more blood, and we find answers faster. So thank you.
Okay, so we'll follow up on that.
Absolutely.
Maybe at MyoCon. I need to make sure that I make make a call out here. If you're not coming to MyoCon and you're in the audience, really register now, because you'll get to meet people like Dr. Huapaya and all sorts of other people who are truly doing everything in their power to advance our understanding of the disease and its treatments. That's where I found out about TMA, changed my life. The other thing that I want to call out is that we have a couple of upcoming events. One we have From Diagnosis to Determined coming next week on Wednesday, Grace, Grit, and Getting Back Up. You can, I think actually that's dropped in the chat how you can register, and also an Ask the Expert session, which is more clinically focused with Dr. Yasmin Ventura and Dr. Satyajit Kusari coming up August 19th. That's a really good place to ask all of your clinical questions. But Dr. Huapaya, I am so delighted to have learned from you today. Thank you so much for sharing the results, but that ambition is what gets me inspired. So keep going.
Thank you so much, Jane, for your kind words. And again, thank you to the Myositis Association, to all the team and all the patients. Without you, none of this could be possible. So thank you.
Okay, over and out. Thanks so much.
Thank you.